darkest roads and up in the clouds. But I've always felt that something's missing. That was until I found you right there in the crowd. You came into my life and started a fire. You made me feel like I could touch the sky. Oh, there's nothing missing now that you're my desire. Now all I have to do is to make you mine. 'Cause I know, and you know what we could be. Like a song, like a perfect melody. Baby, don't say you don't believe in me. 'Cause you know, and I know, we're onto something good. You know, and I know, we got something good.
Hey, Village. How was your Valentine's Day? Mine was like super wonderful. I can't even tell you about it, but it was super wonderful. Just wanted to let you know that. Listen, thank you so much for joining me again. I don't take it lightly that you're joining me every Sunday. I am your host. Welcome to the Village. Let's just talk about a little bit about housekeeping items here. I definitely want you to like, share, comment. This is one of the most important shows that we've had. So please share with your the men, the loved ones in your life. Okay. So today's topic is going to be normalizing the conversation around erectile dysfunction and prostate cancer. I'm super excited today to tell you a little bit about my host. I have Dr. Hugo Davila. He is the former director of urology, but now has his own practice with the Indian River Urology team. He is a certified diplomat of the American Board of Urology and a member of the American Urological, I know I said that wrong, Association. Village, please help me welcome Dr. Davila.
Thank you, Kim. Thank you very much. Thank you for allowing me to connect with your village. You have been very kind with us.
Well, I know I kind of botched up some of your your bio because that's some high tech PhD high square carry to one type situation there, and I wasn't ready.
No, you can call me Hugo. No worries. No worries at all.
So listen, I want to go ahead and dive right in. This is a very serious topic. February, we have dedicated to men, so I want to educate them and start off with talking about prostate cancer. Can you tell me some of the warning signs that they might experience to know if they need to get a checkup?
Well, most of the time now, the prostate cancer is not diagnosed by symptoms. We diagnose prostate cancer too early for the patient to start presenting with symptoms because most of the time we go by the blood test, and the blood test that is more commonly used is the PSA. However, we still have patients that never have a prostate cancer screener. They never came to a physician, and sometimes they start presenting symptoms because the prostate cancer is advanced. And then one of the symptoms that they can present is blood in the urine, blood with ejaculation, frequency, urgency, sometimes urinary retention, meaning that they're trying to empty their bladder and they're not able to empty, back pain, bone pain. So when you start having some of these symptoms as a urologist, you usually get very concerned about it.
Okay. And what would be the age to start getting tested?
Well, the American Urology Association recommend to start screening after 40 to 50 in those patients that are at high risk. Okay, so who are at high risk for prostate cancer? So if you have a family history, so if your father has prostate cancer, then you have a 3 to 4-fold increase of having prostate cancer. So maybe it's recommended to start earlier. And as well, if you are African American, you have a more aggressive sometimes behavior of this prostate cancer. So if you have a family member, then you have to be more proactive. In general, we recommend between 50 and 70. And it's only in these select cases with family history that you have to start a little earlier.
Okay. And so that is an annual exam or biannual, twice a year. How often do they need to do that?
Correct. So it's usually between 50 and 70 every year. But if you see, you have been, checking Mr. Smith for many years, and his PSA has remained stable, his prostate is not enlarged, you have not felt anything, hard in his prostate, then you can space this every other year. But usually, when I get to know some of my patients, new patients, I like to do it once a year, and based on how they behave over time, sometimes you can space it.
Okay. So if a person has history of it, can they get it removed just to kind of alleviate any kind of concerns? Is that an option?
No, no, no. But that's actually a good question, because for females, sometimes when they have history of breast cancer, that there are some indications to do that, and that question is actually asked by many patients to physicians. But in prostate cancer is different. So we don't do preventing surgery, removing the prostate without any indications, because there are side effects that can affect your quality of life related to the surgery, related to the radiation. So you really want only do the surgery or the radiation when it's indicated based on the prostate cancer.
Oh, okay. Okay. And so is it true, excuse me, or is it a myth that men of color have this, you know, illness more?
Yes, it's more aggressive. It seems to be that behave more aggressive, and therefore we have to be more proactive with as well. Hispanics are in that group as well, so we have to be very proactive with them. Sometimes they don't like to come to the physicians because they don't like to have the prostate exam, but it's very important to tell them that nowadays, even with an MRI, we can try when it's indicated with an MRI, we can see if somebody may need a prostate biopsy or not. So, but the key message here that I always give to my friends and family is make sure that a prostate exam don't prevent you to reach out to your physician, and a blood test at the beginning, it could be a good start if you don't want to do the full prostate exam.
Okay, okay. And is there any evidence that certain foods help prevent the prostate from going south?
Correct. So there has been some publications that mention that Mediterranean type of food is the one that can benefit the most for the prostate. So if you go to any of the website and type Mediterranean diet, they can give you different options, and
Hmm.
you're gonna find out that a lot of the things that we like and that we enjoy eating, it can help you. One of them is a tomato. Tomato can anything with tomato, it can help you decrease the probability of prostate cancer. So that's the reason, if you like Italian food, that's perfect, because, all that is very rich on that type of ingredient.
Hmm. So I know we deep dived the uh, into the disease, but what is the function of the prostate?
So it secrete a little bit of a seminal fluid. So when you have an ejaculation, it keep the ejaculation healthy, the sperms viable. So when you are forming basically a family, is very important. But once you accomplish that part of your life and you're not looking into having more kids, really the prostate, you can have a completely normal life without a prostate.
Okay, so I think that I want to, kind of circle back because I do know people that have a history of it in their bloodline, and they aren't looking perhaps to have any more children. So would they be a candidate for having it removed? So what would some of the, like you said, there's side effects to it. So what would it
Correct.
look like?
So, it is very important to know that there is, as anything in cancer, is the treatment is related with what type of cancer you have. Is this a stage one, stage two, three, or four? the higher the number, the more severe the situation is. And so it is very important that when you have the conversation with your physician about what is the treatment option, then you need to know, well, what type of cancer I have, how aggressive it is. So if it's required to be treated either with radiation or surgery, there are some side effects related to these that you need to talk with your physician as well with your patient. For instance, when you remove the prostate, then nowadays we do it using the Da Vinci, which is a robotic equipment that allow us to do the prostatectomy. We are able to save the nerve that innervate the penis and decrease the incidence of erectile dysfunction. But even though that we do that, sometimes patients will end up developing ED or decreasing the ability to keep an erection. So, and you need to talk with your surgeon and say, hey, in your outcome, when you do this surgery, is a 5%, is a 10% incidence of erectile dysfunction. And all of us has that number and we can share that with you, okay? So
Mm-hmm.
if when you are about to do a surgery, you ask, hey, Mr. Smith, from 1 to 10, so how good is your erection? And 10 is the best erections that you have back when you were in the high school. So they tell you, well, right now, Dr. Davila is a 5. So, okay, so most likely you're going to keep the 5 after the prostatectomy. But about 5% of the time, that 5 may become a 3. And then, so what are we doing to prevent that to happen? So sometimes we give any of these medications that are available for ED, and we start giving that before the surgery. And you keep taking that in regular basis. We do it, every day or every other day to keep the blood flow to the penis before the surgery and after the surgery. And by doing that, we are hoping that you remain with the same erections that you have before the surgery. Okay.
Okay.
Another side effect that you have related to surgery is what we call urinary incontinence, meaning that you leak. So if you cough, sneeze, or laugh, or you playing golf, tennis, sometimes you can leak. And usually, right after the surgery, that is very common, but usually it get better, and that can be present in about 2% to 3% of the patients after surgery. And then, how can we prevent that to happen? So, well, we do some exercise right after the surgery, that you come to the office, and then we stimulate the sphincter, and then we make sure that the pelvic floor recover and give you that ability to hold the urine. So, but as you see, removing the prostate is not completely free of side effect, and therefore
Mhm.
that is the reason that you have to do it only when the patient needs it. Radiation, which is another type of treatment that you have for prostate cancer, as well can give you the same erectile dysfunction, incontinence, and then is something that you need to discuss with the radiation oncologist before you move forward.
Okay. Well, I mean, it is just my hope that as we normalize these conversations, that anyone in the village that needed to be informed is getting the information they need from this episode for sure. So let's kind of turn the corner over to the erectile dysfunction conversation. Um, is there an age where men typically stop getting erections, or and if so, are you seeing younger men do experience ED now?
Well, yes, it's very common. I see it all the time in my practice. Anybody who become 40 or older, you start having problems with erections, okay? Some of them can be mild, others can be more severe. But it's a misconception that ED is only going to happen in somebody who is 70. So it can be as early as 40. So don't feel ashamed if you see that your erections are not good, there are many options. A lot of people are having the same problem. Of course, you go to a party and somebody next to you is going to tell you, hey, I have diabetes, I have high blood pressure, but nobody's going to tell you that they have ED. So it
Hmm.
is a very private conversation, but it's common. So that's number one. So don't feel bad to have that decrease of erections if you are older than 40. Then about 20% of the time. You will be surprised. And the reason I like to highlight this is because it's very common. About 20% of the time when the patients come to my office, I review other medications. And there are sometimes other medications, the reason that they're having erectile dysfunction. So
Mhm.
sometimes I tell them, hey, guess what? So I'm going to call your family doctor and I'm going to ask them if they can find another medication for your high blood pressure because this one is maybe the reason you get in the ED. So, but 20% of the time we can fix the problem just by looking the medications that the patient is taking.
Okay.
As well, another important finding about ED is that there are a lot of publications that show that ED usually appear 3 to 5 years before somebody start having heart problems. It's like an early indication of heart disease. So, and what we are doing more frequently is when we have somebody who is 45, 48, hey, Dr. Davila, I'm not having good erections. And I ask them, who is your family doctor? Do you have a cardiologist? Do you have any chest pain, short of breath? Because maybe this is something that we need to address now and not in 3 or 5 years later. Okay, so as I say, is opening the conversation is always the first step.
Okay. Um, when I was putting the questions together, I asked a few of my male friends, what would they want to know? And one of the questions they wanted to know was, could erectile dysfunction be a end result of taking Viagra?
No, no. There is, and I know most likely from where they coming from. There is something that is called priapismus, which is as when you have an erection for that is longer than 3 to 4 hours, and then you have sometimes a permanent damage to the penis, and your erections will be affected. I have not seen any of these cases for the many years that I have been in practice related to the medications that you take for ED. I have
Hmm.
seen these related to drug use, cocaine, trazodone, lithium, sickle cell disease, and which is is a disease that is as well very common in patients that present with priapismus. Then you have to be careful. If you have an erection that is not going away and is lasting more than 3 to 4 hours, you have to go immediately to the ER.
I mean, just, in my own mind, I'm thinking if it lasts longer than, hour, hour and a half, I'm thinking, you need to seek some help. I mean, at 3 hours, I'm thinking, you should be busting down the door at the ER center. So for
Well,
a
Kim,
person,
let me tell you this, you are right. But the problem that we have with the males is females, they are very open to look for and search for physician and care. Males are notorious for not, they don't like to go to a physician. They don't like to go to the ER. When they come to my office by themselves and say, hey, how you doing, Mr. Smith? I'm doing fine. Why are you here? I don't know. My primary care sent me. But when they come with the wife, it's different. So I think there is a different approach to our health. When a man has a problem, they try to hide that, and especially
mhm,
especially in that area, is something that they don't want to be too open and going to places saying what happened. But please, it is very important. Anything that lasts longer than 3 hours, look for a help. And I agree with you, Kim, as if they start having even an hour and a half, go to the ER and see what happened. Sometimes, I can tell the patient, put some ice at the base of the penis. You can get a warm bathtub and see if that is going to go away. And sometimes that helps.
okay. So for those that have been diagnosed with erectile dysfunction, can it be reversed? I mean, is there something that can be done so that they are not taking anything and now they have a permanent solution?
Yeah, yeah. So we go from the less to the more invasive approach. So the less approach, as I told you, we look for medications. If we don't find any problem there, sometimes we ask the patient, especially if he's young, trying to lose weight. If the patient is diabetic, please make sure that you control your diabetes. We give them any of the medications that are in the market to see if this is going to help them. And then if they fail that, then we go for other options. Other options are injections. Of course, before we have all these medications in the market, before 1998, we used to treat this problem with injections in the penis. But
Oh, wow.
yes, as soon as you tell the patients that they need to give an injection and you tell them where, they say, I don't want that. But
Mm-hmm.
it is not painful. The needle is very small. It's smaller than, it's almost like an insulin needle. So they don't really feel it. Okay. So that will be the next step. If the patients fail the medication by mouth, the next step is an injection. If they say, we do different type of injections and we're not able to have a good response, or they say, Dr. Dávila, I don't want an injection, then there is another medication that is like a suppositorium that you put in the opening of the urethra at the head of the penis, and by putting that a small pellet there, it dissolves and give you an erection. Okay, the problem with that
Mm.
is sometimes it give you an erection with pain, and you have to keep it at 4 degrees, so it break the flow of hold
Okay,
on.
wait. You have to keep it at 4 degrees?
Yes. So
Okay.
yeah, so a lot of patients say, hey, Dr. Davila, this is breaking the flow of having intercourse, because you have to say, wait, they look it for, they have to insert it. So sometimes they don't like. There is another
Okay.
option that is what we call a vacuum pump. Is like a cylinder that you put on top of the penis, and you get an erection, and then you put like a rubber band at the base, and then you have sex. But a lot of patients, they don't like this. And then you say, to answer your question, what is the best option is to do surgery. And the surgery that we do is we put a penile implant inside under the skin, and then you will have an erection as when you were a teenager. So you don't have to think about it. You just pump it. You have a little pump that it can give you the fluid inside the implant, and then that implant will be able to have intercourse. And then when you're done, you press a little button next to the pump, and that will release the erection, and then you will be exactly as you were a teenager. The downside is it's a surgery. It's a surgery that take about 30 minutes under anesthesia. You go
Mm-hmm.
home the same day. The side effect of this surgery, or the complications that you can have with this surgery, is infection. Of course, every time that we put something that doesn't belong to your body, it can be rejected. And this, if you belong to that 1 or 2% of patients, then you need a second surgery to remove it, and then you're not going to be happy. But 98% of the time is doesn't get infected, and it lasts for 8 to 10 years. So really, the patient, this is the best way to have freedom of intercourse as when you were younger.
Okay. So when it comes to erectile dysfunction, yes, I know it's medical, but could it be a psychological situation where that is causing the dysfunction?
Yeah, sometimes performance anxiety. I have patients that they have a new relationship, and they tell you, look, in my previous relationship, Dr. Dowell, I never have any problem, and now I have these, and I'm having problem. And then you start building up the confidence with any of these treatment that we discuss. And of course, we always start with the medication by mouth. And then when they see that they can perform well, that is a problem of a society, then they start building up that confidence and allow them to have the erections that they had before.
Okay. Um, I kind of want to pivot just for a minute. One of the things that you said when we did our pre-interview was that you, as a urologist, you're not only seeing men, that you also see women.
That is correct. And there is like a misconception that urologists only see males, and we only deal with prostate cancer, and that's it. And yes, we see a lot of prostate cancer patients, but about maybe 60% of my practice are females. Okay, so and what are those female problems that can be seen by a urologist? You know, kidney cancer can be in male or female. Bladder cancer can happen in male or female. Kidney stones are actually increasing in females or more than males. If frequency, urinary incontinence, when you have a cystocele or rectocele, and you know, meaning that you have a prolapse, then you can see a urologist, a gynecologist. So is and that is the reason that sometimes a lot of patients, they don't think that they can talk to a urologist other than prostate cancer.
Hmm. Okay. So we have about 4 minutes left. What is it that you want to make sure you get across about the prostate cancer and erectile dysfunction? If you just could, sum it up in two minutes and make sure you get that message out, what would that be?
Well, number one is when you are 40, you start going to a urologist, okay? And then
Mhm.
between you and your urologist, you will decide if you need to be screened before 50 or not. But that conversation from 40 and above is going to allow that urologist to get to know you and see if you are a low risk, high risk patient, okay? And at the same time, you can talk about, are you having problem with erections? And if so, what are the options that you have? Another problem that we see, and then we didn't talk today, Kim, but we can talk in the future, is low testosterone. Okay, low testosterone is something that happens very common in male, and especially after 40, and then they start having low energy, low libido. So all that conversation have to start with the urologist in somebody who is 40 and above. Okay,
Okay.
so don't feel that as soon as you step a foot into a urology office, everybody's going to get a prostate exam, and that's the reason a lot of patients are not avoiding to go to a urologist. Having a conversation, getting a blood test is going to open the door to see if we need to do more things or not. Okay.
Hmm.
So that's number one. Step one is get to a urology office, ask with your primary care physician if you can be referred to them, and then they will discuss with you different options and different screening tests. Now, prostate cancer is the most common cancer in men. So we need to know that. We cannot, the same way that our female patients are so proactive with breast cancer, we need to be equally proactive with prostate cancer. Talk about it, discuss it. Don't feel that this is the end of the world if you get prostate cancer. We diagnose about 190,000 men of prostate cancer every year, but only about 29 to 30,000 will die. So a lot of patients will not die of prostate cancer. So therefore, it is important that you understand that this is the most common cancer that you can have as a man. And then another important thing is if you start having problem with erection, hey, be careful with your heart. Maybe this is an early indication. ED is an early indication that your heart in the future will have a problem. So make sure that you check your weight. You're not overweight. You make sure that you're not diabetic. Make sure that you don't have high blood pressure, high cholesterol. All those things can end up at 45, 55, you ended up having a heart attack. So ED is an early sign of a heart problem in the future. So keep that in mind.
Okay. This has been very informative, and I'm so glad you were able to come because we do need to normalize this conversation. I don't necessarily see where women are getting involved to help the men in their lives. And so I thought it was really important to kind of bring you on, allow you to speak to us, educate us, and and give us all the tools and information that we need. So thank you so much for coming. It's been a journey to get here today, as you know. But but I will monitor the feedback and perhaps we'll be able to bring you back. But I just want to say thank you on behalf of the village.
Thank you very much for inviting me, and I'm looking forward to continue working with you.
Okay, thank you so much and have a good day. Village, come on now. That was phenomenal, full of information and just practical steps that anyone, any male can take to ensure that their health is 100%. Please have the conversations. We only have one life. This is not a dress rehearsal. So, by all means, take the necessary steps and take care of yourself. And remember, silence creates distance, but conversations with Kim builds the village. Thank you and bye bye.
So you don't